Okay, so we'll get started. Good afternoon, everybody, and welcome to the latest OAK seminar. We have a special seminar today on Friday afternoon because our speaker, who I'll be introducing in a couple of minutes, is speaking to us all the way from Italy. So keep in mind that she is 6 hours ahead of us and has graciously agreed to speak to us, even though I'm sure there's many different, better things she could be doing on a Friday night than giving a lecture. My name is Vinay. I'm the host of the seminar today. I'm an instructor in our graduate department, Periodontics. Some housekeeping. I want you to type all the questions that you might have under the Q&A icon at the bottom of your screen. So click on that, type in the question, and we will do our best to get to as many questions as we can at the end of the lecture. The question and answer session will be moderated by our very own dear final year residents, Drs. Hunter, Dr. Javidnia, and Dr. Nguyen. And for all those who may be joining late or may not be able to join us but have registered, the presentation will be recorded and will be available for on-demand consumption shortly thereafter. So now let's get on to the main event of this afternoon, evening, and morning, where some of you might even be. We are extremely delighted to have Dr. Ilham Munseef, our colleague and friend, join us today. As I mentioned, we're having this lecture today because she is speaking late into the evening hours. When we first started the OAK seminars, our intention was to bring you experts in the field of periodontology and implant dentistry to give you lectures on relevant topics that were based in solid, concrete evidence. And all of our speakers so far have been from North America. So it's really, really nice that with our audience being so global, that we even have global speakers now. So Dr. Ilham Munseef is the first real international speaker that we've had. I want to tell you a few things about her before I give her the stage. So she completed her dental training at the University of Bologna, after which she pursued her master's in periodontology and implant dentistry from the University of Siena in Italy. She wasn't quite finished there yet, as she went on to further obtain her master's in forensic odontology. So yes, she is like a CSI dentist as well, from the University of Florence. She's currently a clinical professor and researcher at the University of Bologna. And in addition to academic position, she also maintains a private practice in periodontics and implant dentistry. And she's a consultant in forensic odontology as well. She has lectured internationally and nationally and has published numerous original scientific papers in high-impact peer-reviewed journals. She's going to be speaking to us today about the C word, complications, and how to overcome them with respect to root coverage procedures. And so, Dr. Mounssif, we're very, very excited for your presentation today. And without further ado, I'm going to stop sharing my screen and give you the virtual floor.
Thank you. Good evening to all of you. It's a great pleasure to be here tonight because here is evening. And for me, it's a great pleasure. I would like to thank my friend, Dr. Vide, for this invitation and to all the scientific committee of OAK seminar. The topic today is very interesting and I think very useful and helpful for all of us as clinicians and surgeons, because it regards prevention and management of complication in root coverage procedures. And this is important because the performance of surgery by nature is strictly correlated to some issues that clinicians must face during daily practice. Some of these issues are defined as complication in a strict way, but others of these issues are complications due to medical errors or treatment errors. So just to talk the same language, I would like to share with you these two basic definitions. First of all, complication can be defined as secondary disease or a difficulty factor or issue often appearing unexpectedly and changing existing plans. While we are talking about medical error or mistake regarding an event that is preventable with the current state of medical knowledge. So usually we are so focused on the act of surgery that actually represent only a very small part of a bigger picture that is called therapeutical process, in which, of course, we have a pre-surgical phase in which we have to examine patient, diagnose and make a prognosis, and also a treatment plan tailored to our patient. The main part is regards surgery, and then the post-surgical phase. It is really, really important, in which patient and clinician should work together very hard in order to maintain in the long-term period the achieved result. And all these surgical phases are very full of issues. Some of them are full of medical errors, and I'm referring to the pre-surgical phase that is up to us, basically, and the surgical phase, in which we can have both medical errors and complication. And in the postoperative phase, we have mainly complications. I'm going to see in details all these aspects in this webinar. So let's start from the pre-surgical phase. As I said, in this phase, examination, diagnosis, and prognosis are the base in order to design a proper treatment plan for our patient. And in this phase, we can commit only errors. So it's up to us as clinicians to have a very, very strong background. So the lack of knowledge is the cause of this kind of medical errors. And since we have to deal with human beings beyond gingival recession in periodontal plastic surgery, as well as in other periodontal surgeries, we have to start with an examination of systemic diseases. For sure, diabetes should be checked and evaluated. Also, some other aspects, such as some other diseases, such as coagulopathy, and the intake of specific medication, such as anticoagulant medication and bisphosphonate. For sure, we have to focus also on local factors, because from one side we have plaque-induced gingival recession that are caused by poor oral hygiene and inflammation. And on the other side, we have patients with high oral standard hygiene, and this is usually done due to wrong tooth brushing habits. So before to treat this kind of patient, in both these different type of patients, we have to check their habits, to motivate and to modify their habits in order to maintain over the time the achieved result with root coverage procedures. And surely smoking habits represent an issue for our patient in periodontal surgery in general, but also in periodontal plastic surgery. From literature, we know, even it's very limited, we know that smokers may benefit from periodontal plastic surgery, but with less percentage of complete and mean root coverage compared to non-smokers. So this is something that patients should keep in mind, and also, of course, clinicians. In this phase, I would like to draw your attention regarding a sort of novelty in our field, in dentistry, let's say, and I'm talking about the intake of dietary and herbal supplements. This is something that has been quite investigated by our colleagues of other branches of medicine, such as plastic surgery or orthopedics, because they found that several patients presented an uncontrolled perioperative bleeding due to the overuse of this kind of product. And the outcome was, of course, especially in plastic surgery, a negative results in terms of aesthetic, especially in facial aesthetic surgery. And since we are root coverage procedures are considered plastic surgery, I think might be important also for us as surgeons. So the intake of dietary and herbal supplements basically influence what? The process of bleeding. And you know that the bleeding process is a very delicate and balanced process in which we have several aspects and several molecules that might be the target of this kind of products. They may act as antiplatelet, anticoagulants, both of these mechanisms, or they may participate with other mechanisms such as the interference with the production of vitamin K that is important in the coagulation process. And as you can see here, we have several familiar names, I think, because many of us may intake this product right now. So these are very products that are spreading all over the world among everyone. And just to give you an idea regarding how these products are spreading over the world, these are the data in the Italian market. These are, for me, scaring data, because in Italy, 80% of patients intake this kind of supplements, and only 40% of this intake is regulated by medical prescription or medical advice. That means since these products are over the counter, they can be bought without any kind of prescription by patient, and they can also be overused by patients, because patients think that since they are natural products, they contain natural ingredients, they should be considered safe. And for me, this is very scary, because means that in Italian dental office, 8 out of 10% intake this kind of medication, this kind of supplements. So we can borrow some recommendation from our colleagues of plastic surgery and orthopedics, because dentists, surgeons, oral surgeons, and periodontal surgeons should be very, very aware regarding this intake of medication, the side effects, especially of herbs and supplements, and also make patients more aware regarding this product. Furthermore, we should carefully review this product as much as we review the normal medication and record them in the medical file. And the last recommendation is to stop the intake starting from 2 weeks before the surgery until 1 week postoperatively, in order to control as best as we can the perioperative bleeding that may affect negatively the result of our surgical procedures. After medical examination, we have to diagnose gingival condition. And usually we have in mind this appearance when we think about gingival recession of an elongated tooth. The elongated tooth, as you can see here in this case, might be associated with the idea of gingival recession. However, it is important to remind that in order to make diagnosis of gingival recession, we need 2 key factors that are important according to the definition. So we have to identify the CJ, and we should see also a root exposure. So let's check this case in which we have this elongated tooth. Trying to detect the CJ or root exposure, we are not able to detect them, because as you can see here, we have complete crown and no non-root exposure is present. And the point here is to do the correct diagnosis. So do not misdiagnose a gingival recession, because here we have a 21 that is an healthy tooth, while we have the 11 that is the shorter tooth, that is the tooth with the problem here, and the diagnosis in this case is altered passive eruption regarding the contralateral tooth. And this is another story compared to gingival session. I know that it may sound banal for you expert periodontists, but I think for inexpert or just graduated dentists, this is very important and should not be misdiagnosed. After the diagnosis of gingival recession, of course, we have to make a prognosis. And the last World Workshop in Perio in 2017 introduced a new modern classification to substitute the previous one, the Miller classification. So now we have this modern classification that we have to use that has already been introduced in 2011, in which 3 types of gingival recession are present according to the type of the interdental cal loss, a clinical attachment loss, and also this classification gives us an idea regarding the percentage of root coverage that we can achieve in each class, in each type. And I think that the novelty introduced by the workshop and with these papers published by Cortellini and Bissada is this beautiful table, very, very useful for all of us, because immediately after having filled this table, you have the perfect idea of your surgical plan. And the key point of this paper is now we have to focus not only on soft tissues, including recession depth, gingival thickness, and keratinized tissue, but we have to check and correct the hard tissues. And I'm referring to the CJ and the cervical step. So why now we have to focus so much on this aspect? First of all, we know that the CJ is our reference point to measure the depth of the gingival recession, to measure the amount of root coverage achieved. And in case of the adjunction of a connective tissue graft, we also have the CJ as a reference point for the graft fixation. And of course, for the final position of our coronally advanced flap. Furthermore, CJ in a situation in not optimal anatomical condition may change its position. And I'm referring to all those situations in which we may have rotation, extrusion, cervical abrasion, occlusal abrasion, or we have the interdental soft tissue loss. In all these situations, the CJ change its position and the complete root coverage cannot be achieved in this specific situation. Therefore, we have to identify a new line called clinical CJ and to determine in the new maximum root coverage. And this is something that has been explained in 2006 by Professor Zucchelli and co-workers in this paper, and also the method to how to measure this clinical CJ. And the new clinical CJ is very easy to be rebuilt thanks to a composite restoration that usually should be done 1 or 2 weeks before the surgery. Whenever possible, I suggest to use the rubber dam in order to promote the adhesion. And this is something really, really important to perform before the treatment of soft tissue. Let's see this case together in which we have the CJ that is completely out of its position, because usually CJ should be visible in normal position. Tooth should be visible only in the mid-fascial part, while the mesial and distal part are under the gingival tissues. So in this case, we have, this is the CJ. So the maximum root coverage cannot be achieved only with soft tissue. Therefore, we are going to create a new clinical line that is called clinical CJ using a restoration, as you can see here, and then complete the treatment using soft tissue advancement. Only in this way we can reach a perfect and pleasant result with soft tissue coverage. Furthermore, this is important to understand this point regarding CJ and cervical abrasion, also for the concept of non-carious cervical lesion that sometimes represent 0.5% of the problem, as you can see here. And Cortellini and Bisada in their papers stated clearly that now we have to restore firstly the cervical area, the abrasion, non-carious cervical lesion, and then we can move and go on with soft tissue management. As you can see in this case, firstly, we treated the cervical area using composite restoration, and then we moved coronally. This is a coronal advanced flap alone without any kind of graft in this anterior area. As you can see here, we end up with a very great and pleasant, beautiful result. And this is important because in case of not performance of the cervical, the restoration of the cervical area, we can end up with situation like this, in which, of course, this cannot be our reference point. Okay, so that should be the new clinical CJ, and the restoration should have been done before the surgery. And as you can see, if we perform the surgery before, and in this case, we used also connective tissue graft, so we reached a very important thickness of tissue, we create a very deep step that is not maintainable by patient from oral hygiene, with oral hygiene, because this is very deep, this is very close to this very thick tissue, and become a point of weakness in terms of plaque accumulation, inflammation, and might be one day even a buccal periodontal pocket. So the evaluation of the cervical area and hard tissues is mandatory before treating gingival recession. So now, after this pre-surgical phase, that is very, very important because it's the beginning, we can go on with our surgical phase, in which we have some issues. Some of them might be medical errors, and others are considered complication. So in all this situation, we have some responsibilities, let's say, in terms of lack of knowledge, and of course, in terms of lack of skill, because these surgery are so delicate and so they are so delicate. So we have to reach a learning curve before treating some kind of gingival recession. So let's start to see in details the concept of excessive bleeding. What does it mean? Well, I found several studies in the literature in which they have measured the amount of intraoperative blood loss during periodontal surgery in general. And they found out that the amount of blood loss reported in the literature in this study is ranging between 6 millimeters up to 145 millimeters. And this number, this range, has been considered minimal compared to other type of surgery, such as orthognathic surgery, in which 600 millimeters of blood loss were reported. Therefore, we cannot talk about excessive bleeding in periodontal plastic surgery. Just one recommendation: the intake of anti-inflammatory drugs that should start immediately after the surgery, because in some studies the bleeding during the surgery were evaluated in patients who have intaken this kind of medication before, and they found out that there was an excessive bleeding actually. So immediately we can prescribe this product, so these painkillers, anti-inflammatory drugs, immediately after surgery. I'm talking about especially about ibuprofen. One specific error that might be committed and resulting in excessive bleeding might be the wrong management of split thickness. We know that during the performance or coronary advanced flap, in order to release the flap, we have to perform two split thickness, the deep split thickness that is done keeping the blade parallel to the bone in order to detach flap and fiber from the periosteum, and the superficial split thickness, maintaining the blade parallel to the lining mucosa, detaching fibers from the inner aspect of the flap. So we have basically two inclinations, parallel to the bone and parallel to the lining mucosa. So staying into these planes, the bleeding is physiological. However, if we have a wrong inclination of the blade, in this case, we are damaging the submucosal tissue area that is rich of glandular and fatty tissue, and also greater vessels that are located in the middle of these two planes, and therefore we might have an excessive bleeding using wrongly the blade in this case. Different is this concept on the palatal side, that we know we have to deal with a very important structure that is the greater palatine artery during harvesting procedure. Greater palatine artery, we know its course and its emergence, because fortunately we have landmarks to identify it and to avoid it. And recently, a systematic review published by Lorenzo Tavelli gave us an idea regarding the safety zone in which we can harvest the graft in a safe way. And this is an area ranging between canine and second premolar, and 2 millimeters, starting 2 millimeters from the gingival margin. And in terms of height, it ranges between 5 millimeters at the level of the canine and 11 millimeters at the level of the second molar. So we should consider this area as a safe area, because the course of the greater palatine artery is always located apically. And I would like to share with you this concept, because of course we know that we have several techniques present in the literature to harvest a graft. I've reported some of the most famous or most used, and as you can see from pictures and drawing, all these techniques include a surgical area that is bigger than the graft, the dimension of the graft needed, as you can see, especially the envelope technique, in which we have just one single incision. And it's clear, this is a concept very clear, because in order to harvest something that you can reach only from one incision, you have to go more deeper and larger in terms of mesial distal dimension. And this is the reason why in Bologna we use the Zeptalized gingival graft technique, because this is a technique that you can use whenever is the dimension, the thickness of the palate, the shape of the palatal vault. And you can use it for single or gingival recession. You can use it as a epithelial connective tissue graft or a free gingival graft. And also you can use for soft tissue augmentation, because you can fold a long connective tissue graft into thanks to some sutures. And we have tasted this technique in two different randomized clinical trials. The first one to compare this technique with the classic trapdoor in order to detect which one is more correlated with patient morbidity. And actually, these two techniques are similar in patient morbidity. The difference is in the painkiller consumption that increase by increasing the height of the withdrawal and by reducing the residual soft tissue covering the palatal bone. That means that if you have at least 2 millimeters of palatal thickness to cover the palatal bone, you can go with the trapdoor technique. Otherwise, you have to choose the Zeptalized gingival graft that you can perform whenever is the thickness. The same technique, so the Zeptalized gingival graft, we have tested different dimension of connective tissue graft just to understand if we can use a reduced dimension of the graft with the concept to reduce the postoperative morbidity. And in fact, the results were promising because no statistically difference in terms of root coverage for both groups. So the big graft and the small graft, where the small graft is a graft with a thickness less than 1 millimeter and the standard height of 4 millimeter. And especially for the small graft, we had better results in terms of aesthetic from patient and professional point of view. And of course, less postoperative morbidity because the graft is smaller. I would like to share with you these two movies to show you. I know that you already know this technique, but just two brief videos in which the technique is the same for singular gingival recession. We start with an horizontal incision starting 2 millimeters from the gingival margin at the palatal site, 2 vertical releasing incision, 1 mesial and 1 distal. The horizontal incision is made 1 millimeter sharp, and then we can go parallel to the palatal mucosa, calibrating the graft and creating an homogeneous thickness. Once we are satisfied with our thickness, we can harvest using a second horizontal incision, apical. As you can see, the bleeding is easily controlled, and that can be done using a sponge, fibrin, collagen sponge, or sutures, compressive sutures. Of course, during this technique, we might have some issues related to our technique. Therefore, if we have a normal or moderate bleeding, we can compress with gauze, dried or soaked with hemostatic agent. We can use collagen sponge, and we can use sutures even with big thread, and we can use, if there is an extensive bleeding, we can use also silk to suture perfectly. But when the bleeding is very excessive and maybe we have damaged the greater palatine artery, unless we are very expert as surgeon to clamp the artery, I think that it's better to call the emergency, because usually after the cut of the greater palatine artery, this tends to retract. Therefore, it's very, very difficult to clamp it. The second issue that we might face during the treatment of gingival recession regards perforation. That, of course, is a medical error because a surgical error. And basically, perforation is an opening of the rupture of the integrity of soft tissues, and that usually happens during the performance of superficial split thickness. This is the case in which the multiple gingival recession have been treated using the envelope flap, and you know that in this technique the peripheral area should be tunnelized. As you can see, the wrong inclination during the split thickness might determine small, in this case is very small, but it may determine some perforation. While perforation are very small, as in this case, we have to not do anything more, because as you can see, the healing was very perfect without any kind of suture in this case. But often when we create perforation, they might be even bigger, as you can see here in this case. creating perforation between the central and the lateral. And the complication here derived from the fact that we have to add a second graft that otherwise we wouldn't have put. And I'm referring to this one at the level of the 21, because this tooth has a great amount of keratinized tissue and thickness, so no need for a graft. But with this perforation located here, we couldn't risk, okay, in this aesthetic area. So after the suture of the marginal part of the flap, we have to fix the perforation. The suggestion is always to use very small needle and very small thread to treat this area in order to adapt in the more precise way the borders of the perforation. And as you can see, the healing was very, very good, even though we had this kind of issue. I'm presenting another case of perforation. This is something interesting because the treatment of maxillary molar, or in general of the posterior area of the mouth, is quite challenging because we have reduced visibility, we have strong muscle insertion, and also in this case we have the lip retractor that reduces the visibility. And if you treat with vertical raising incision, it is even more challenging. In fact, as you can see here, during the performance of split thickness, the issue came up as a perforation here in this area, as you can see. Okay, so the point is to do not panic, of course, firstly, and then we need to overcome the perforation. So first we go with the small periosteum elevator, to overcome the perforation. Then once the perforation is overcome, we can go back with the blade and trying to release more the flap, because this is the point, the final goal. So we need to move coronally in a passive way the flap. And performing this kind of surgical step, the perforation might enlarge. This is why, and because of the presence of the distal vertical releasing incision, this is why we chose to close perforation first with 2 or 3 sutures, just to not allow a further enlargement of perforation. As you can see here, we use always very small needle and very small thread. After the closure of the flap, so the vertical raising incision and the sling suture, we can finish the suturing of the perforation, adding more sutures if we need, and trying to put the borders very close in the best way. And as you can see here, the treatment was very, very successful despite this kind of occurrence. The modification of the plan here was to use a graft bigger than usual, because as you can see, this is a very high graft that we have used to compensate the perforation present in this area. Last case that I'm sure you are going to love, this perforation regards this very difficult area. This is the anterior mandibular area, in which we have some limitations in terms of surgery, because we have very often we have shallow vestibule, very deep gingival recession, very thin soft tissue, root prominence, and often we have to create a brand new flap from the mucosa of the lip. And this is usually performed using the superficial split thickness, as you can see here. And in this particular case, a perforation was made exactly in this very small and delicate flap that we are creating from the mucosa of the lip. But as I said before, we need to go further and to release completely the flap. As you can see here, we are performing the superficial split thickness in order to detach the flap that we are creating from the mucosa of the lip from the underlying tissue. That is basically the submucosa. Here we have, and then we can go. I'm going a little bit faster. We can go further with the suturing technique of our flap. In this case, connective tissue graft was already planned, so we didn't change anything in this case. As you might know, in the anterior mandibular area, our technique include reverse suturing technique, because we start with the sling suture in order to perform in a more comfortable way this apical periosteal suture. And we have chosen to close one side, one vertical region firstly, then the perforation, because otherwise it could enlarge more. So this is one important thing is to not engage the underlying tissue. Okay, so we have just to put together the borders of the flap of the perforation. And as you can see here, we are using small needles and small thread. This is a 7.0 thread and 8 millimeter needle, or even 6.4 millimeter. We are just closing some part of this perforation that we are going to finalize at the end of the surgery, after having closed even the other vertical releasing incision. And as you can see here, this is a very delicate tissue that should be managed carefully, because otherwise we could lose completely this tissue during the healing. And I don't know if it was luck or what else, but as you can see here, the healing was absolutely perfect. This is the clinical aspect at 14 days after suture removal. And this is 1 year result, in which we have perfect soft tissue integration and complete root coverage. So just to give you some general rules for the treatment of perforation, this is of course something that is based only on clinical experience. So usually to not suture small perforation 1 or 2 millimeter, lying on the vascular area. We need to suture big perforation, more than 2 millimeters, but lying on vascular area. And whatever is independently from the dimension of the perforation, in presence of perforation on the avascular area, meaning on the root surface, we have to suture and add the connective tissue graft, if not planned, because otherwise we may end up with a fenestration. The third issue in the surgical phase is the nerve injuries. During the performance of periodontal plastic surgery, we have to deal in the fascial aspect with 2 nerves, the infraorbital nerve and the mental nerve. For the first one, fortunately, I've never experienced this kind of occurrence. Why? Because the emergence of the infraorbital nerve is very apical. It is located under the zygomatic bone. And usually this is very far from the area that we are treated, because if you perform correctly the deep split thickness, you need just a small amount of deep split thickness, because as soon as you can position the blade parallel to the lining mucosa you can go immediately superficial. And doing this superficial split thickness, you are far away from the emergence of the nerve, because we are working on soft tissue and not at the level of the bone. Different is the concept regarding the mental nerve that we have to face during the treatment of premolars. First of all, I recommend to use to do an X-ray before the treatment in order to detect the emergence of the nerve, so the height of the nerve, and also for medical legal issue, to prevent medical legal issue. So in this case, it is mandatory to not perform the deep dissection. So we have to perform only the superficial split thickness, because otherwise we can damage the emergence of the nerve that is located at the level of the bone. So after the use of an elevator, and after having enlarge the length of the vertical raising incision, we can substitute the deep dissection with the gauze technique. So a gauze using 2 fingers and pulling the flap, pushing the flap towards the apical direction. In this way, we can release the fiber insertion that are present between periosteum and the inner aspect of the flap. And thanks to the use of tweezers, we can open the flap and see perfectly this difference. Okay, as you can see here, staying parallel to the flap, we can detach fiber by fiber, one by one, from the inner aspect of the flap. In this way, we are able to release completely the flap without touching this middle part, that is the submucosal tissue. And here we can have, in this apical part, we can have the emergence of the nerve according to the height that you have already seen in the X-ray. So be careful with this area. And the last but not the least aspect for the surgical phase to keep in mind is the surgical stability. Surgical stability means basically the suturing technique and how we adapt the flap at the end of the surgery. For the coroner's advanced flap, we have the interrupted suture if we are performing also vertical raising the incision, and at the level of the marginal area, we have the sling suture. And the concept of sling suture is that these sutures are very, very strong because they are anchored around the palatal or lingual cingulum of the tooth. So they are anchored around a very fixed point that is the tooth, basically. And our goal is to reach this complete the perfect tight adaptation of this area above of this marginal part of the flap, above the convexity of the crown, as you can see here. And non-oozing or bleeding should be visible at the end of surgery for that part, because otherwise we have to do more sutures in order to adapt better, because this is the base to promote the wound stability, the early wound stability. So this video shows you the suturing technique, especially the sling suture, as you can see here. And the sling suture are performed around, are anchored around the palatal cingulum, and the goal of this suture is to tight as much as possible the marginal flap area above the convexity of the crown. So now we have reached the last part, is the post-surgical phase, that is very, very full of issues. Of course, some of them are medical errors, very few, and most of them are complication. And I've grouped them in a didactical way, starting from the most frequent up to the less frequent. I would like just to remind you that it is very, very important in our periodontal surgery to keep and to make patient aware regarding the postoperative period. So give them postoperative instruction in a careful way in order to make them aware, in order to make them able to manage their complication, especially because the complication usually happens at home, maybe during the weekend, and they are not able to manage them alone. Pain and swelling are quite common after the performance of surgery for every surgeries actually, and the pain, it might be controlled very well using painkillers, anti-inflammatory drugs, while swelling has been reported that ice packing, even with limited evidence, might be helpful. Regarding pain, just remember that 3 factors contribute very well to pain perception. And I'm talking about the duration of the surgery, because the longer is the surgery, the more is the pain perceived by patient. In fact, a recent study reported a threshold of 6 minutes of duration to distinguish between mild and moderate pain perceived by patient, measured on a numerical scale. Smoking, smokers reported more pain compared to non-smokers, and this might be due to the less vascularization during the early healing phase. And lastly, the surgeon experience, but I'm referring to the experience in terms of tissue manipulation. So the less traumatic manipulation of tissue determine better healing and therefore less pain perceived by patients. Hematoma is strictly correlated to this kind of flap because it's due to flap releasing, so to the split thickness that we perform to release the flap. And it might happen at the level of the skin, so the facial area, or very localized at the treated area, so intraorally. This is a self-limiting issue, not painful, and no medication are usually prescribed. I think that the concern might be regarding the aesthetic appearance of this occurrence. So once again, it is important the post-operative instruction of our patient, especially all those patients who maybe works with their aesthetics, let's say, okay? The bleeding at primary site is quite uncommon because if there is some bleeding at the primary site, something of course went wrong. And we have in the literature that the bleeding in the primary site may range from blood-tinged saliva up to an aggressive oozing, up to this manifestation that is called liver or currant jelly clot. That is a very scaring, let's say, appearance. However, it's very easy to be managed. First of all, we should investigate the cause of this occurrence, because often it is a traumatic event. So chewing, tongue forces, pulling the lip, or an excessive swelling during the early postoperative period. Therefore, some sutures may be lost. And in this case, we have to remove gently using a gauze, dried or soaked with hemostatic agent, to see perfectly the flap and what went wrong. Because if some sutures were lost, we have to do them again to promote a new the new healing, let's say. And this occurrence may happen extensively, as you can see at your right side, or in a localized way. But the management is exactly the same. We have to remove, to check, and of course to renew the post-operative instruction for patients. Bleeding at the level of the donor site is more common, especially if we have harvested the graft using a deep graft, let's say, or deeper techniques compared to the depitalized gingival graft. And the treatment, the management of these sites are very, very easy, because we can compress, we can do more sutures, we can use hemostatic agent. We have to renew also for this, for in this situation, patients regarding traumatic events such as tongue forces or chewing. And I suggest to solve by yourself this problem, because sometimes patients go to the emergency, but they are not so used to solve this problem. So it's better to fix by yourself this kind of occurrence. At the level of the palate site, we can have also necrosis of the flap. That is something that is self-limiting. Let's say maybe it's a little bit more painful for patients, but in 3 weeks, 4 weeks, disappeared completely. And the point here is that despite the adequate dimension of the flap covering the palatal bone, there might be some chemical or thermal stimuli that may determine this kind of occurrence. Okay, so it is not a medical error. It might be if the dimension of the thickness was not adequate, but it may appear also as a strict complication. And this is something I think very important for you all, because flap dehiscence is a sort of nightmare after root coverage, because especially when patients have static demands. And basically flap dehiscence is let's say a separation of 2 layers that have been previously stitched together. And according to the technique that you have adopted, you can have complete failure in case of coronally advanced flap alone, complete failure of coverage, or the exposure of the graft, or the exposure of the collagen matrix. We have to understand why this happens, because this is very important in order to avoid or to reduce the occurrence of flap dehiscence that sometimes occur even in presence of a perfect surgery. So no kind of errors committed. First of all, let's see this case together. We can clearly say that this is not a well-executed surgery, because we have some issues here. First of all, some tension in this area, then a perforation. And the most important thing, 2 important things, are the bad adaptation of the surgical papilla above the anatomical papilla, and the inadequate depitalization of the anatomical papilla. And this might heal more or less good, let's say. But as you can see here, even after several months of healing, we still have this appearance that is not pleasant at all, and might represent a huge aesthetic concern for patients, especially in this area. So let's try to understand which are the problem here. First of all, flap tension. We know that the tension should be completely removed using the split thickness. Okay, so the flap should be able to be moved in a passive way without suture. Okay, so we do not have to use sutures to move coronally the flap, because otherwise during the healing the flap tends to shrink, and therefore that might be an opening, so a dehiscence may occur. The second important aspect is papillary dissipatization, because papilla represents our reference connectival bed, our connectival bed and vascular bed for the marginal part of the flap. So it is important to create a connectival bed without epithelium in order to adapt the surgical papilla above the anatomical papilla in the final phase. And this is done using two tools. The first is the blade to remove the most part, and then the microsurgical scissor to remove the most coronal tip of the anatomical papilla. And this is a very fundamental step in this surgical procedure in order to reach and achieve great results. And at the end, as I said earlier, the surgical stability using a perfect suturing technique to adapt the marginal flap above the convexity of the crown in a tight way. No oozing, no bleeding from the sulcus should be visible. And the flap dehiscence are even important in the mandibular anterior area, in which we know that we have several obstacles to our treatment. And with this study, we have shown that the submucosal tissue removal, that is the removal of this tissue located between the bone and the mucosa of the lip, that is rich of glandular tissue, fatty tissue, but also muscular tissue, we can have better results in terms of complete root coverage, in terms of less flap shrinkage, in less graft exposure, and no difference in terms of more postoperative morbidity. So performing or not performing, the submucosal tissue is exactly the same. And this is something that I recommend in this area in order to reach the best outcome. And what we can do in presence of flap dehiscence. Of course, we have to wait. We should, biology should do its course, because this may heal even in a beautiful way after some months, at least 2-3 months. Then we have to check with patient what is our goals in that moment, because if we are satisfied about the amount of root coverage, the soft tissue integration, as you can see here, despite the flap dehiscence at the beginning, we see here a beautiful result that might be satisfying for patient. But if we have partial root coverage or bad soft tissue integration, we have to check the situation with patient, and then in case of unsatisfied result, we have to do a new surgery. So just to summarize, flap dehiscence might be due to bad flap mobilization, inadequate papillary dissipatization. In the anterior mandibular area, the submucosal tissue is recommended to prevent the early flap dehiscence, the adequate marginal stability, and of course, the final position of the flap that should be always positioned 1-2 millimeters coronal to the level of the CJ in order to cover CJ and graft when it's used. Sometimes we have patients that represent our biggest complication. This is a very funny video that I would like to share with you. This is a video of a colleague of mine, and that patient sent him 2 days after surgery. As you can see, patient have already pulled his lip, and as you can see, we have already a flap dehiscence. So sometimes patients behave in a way that cannot help our surgery, even we performed everything in a perfect way. In the behavior of patients after the treatment, surgical treatment is fundamental, especially in the mandibular anterior area. So sometimes I recommend to scare patients regarding the consequence of their behaviors on the surgical procedures. And partially correlated with flap dehiscence, we may have this kind of occurrence that is called graft exposure. An interesting point introduced in 2009 by Chiron co-workers underlined the importance of root coverage amount together with soft tissue integration. In fact, in 2009, Chiron introduced the root aesthetic score, that is a professional score to assess the aesthetic outcome of root coverage procedures. And this is a score ranging between 0 and 10, in which 10 is the maximum score achievable, so the best aesthetic result, and which complete root coverage is 6. So we have other 4 parameters correlated with soft tissue integration, meaning texture, volume, position of the gingival margin together, that work together with the root coverage. And this is a very important aspect. And it's even more true for patients. In fact, in 2014, Kim and co-workers published a study in which they found out that patients scored better soft tissue integration rather than root coverage, meaning that they scored better aesthetic outcomes in terms of color and texture than the complete root coverage. They are not so interested in complete root coverage, but more in soft tissue integration. And with this in your mind, you can understand how this may impact the aesthetic outcome and why this might happen. We can have a wrong position of the graft, of course. Therefore, the graft might be positioned too coronal, and it should be located at the level of the CJ or 1 millimeter apically. We have the dimension of the graft, so thick graft and the bigger graft are correlated with the worst aesthetic result, as I showed you before. Also, the early flap, the dehiscence of the flap in the anterior mandibular area or in other zone of the mouth, the early flap dehiscence determine the the exposure of the graft in the that is located below, and of course the post-surgical margin position of the gingival margin at the end of the surgery. And different is this concept when we talk about matrix, because in case of flap dehiscence, the graft gets exposed, and so the healing is mainly up to the graft exposure. When we put a matrix in as substitute of connective tissue graft, this kind of matrix are introduced to be completely submerged. Therefore, after their exposure to the oral cavity, they tend to resorb. I would like to share with you this case that we have published in our exploratory clinical study last year, in which we have treated this canine, as you can see, using Coronal Advanced Flap Plus a volumetric collagen matrix. And this is a case in which, as you can see, the collagen matrix is always very, very big compared to the graft, because we need to compensate the resorption. After the perfect treatment, we end up with this matrix exposure, as you can see here, the level of vertical releasing incision. However, after 50 days, as you can see here, 1 month, we have great result without any kind of appearance of these issues. And this is the result after 6 months. It's very beautiful, soft tissue perfectly integrated and complete root coverage. Of course, this is an exposure located at the level of the vertical releasing incision. In case of the exposure of the marginal part of the flap with the consequent exposure of the matrix, we might end up with a partial root coverage. So, let's say a recurrence of part of gingival recession. And correlated with graft exposure, we can have keloid-like appearance, as you can see here. That basically keloid-like appearance is a change in volume, in texture, and in color, and usually may appear at the level of the gingival margin after the graft exposure, as you can see here. But the keloid-like appearance may occur even in after several months of perfect healing, resulting in this kind of situation in which we do not have a change in volume or in and in color in volume, but we have just a change a little bit in texture and of course in color, because as you can see here it is white. How we can fix this keloid-like appearance? It's a very hard answer because we can try to fix it. Firstly, performing in gingivoplasty using a bar and modifying the texture and the volume. But we can't work at the level of the color because the palatal graft is always whiter than the attached buccal gingiva. Therefore, even we can change the texture and the volume, the area always will appear a little bit lighter. In case of incomplete satisfaction of patient, even after gingivoplasty, we have to perform a gingivectomy to remove completely, like in this case, this area. And then we have to do a new surgery to cover the small recession that we have created with this gingivectomy. Similarly to keloid formation, we have also scars that are appearance, flat and white appearance, and that are mainly correlated with vertical releasing incision, especially at the level of the alveolar mucosa. And this is the reason why we recommend to perform very short vertical releasing incision, and also to avoid the root prominence to perform vertical releasing incision. But this might be due also after the periosteal sutures that we can use at that level to fix the flap, to close the vertical releasing incision, because the periosteum is engaged during this type of suture. One more recommendation also for vertical releasing incision is to perform the cut beveled in order to not involve the deep tissue, so periosteum and bone, in the heel, in the superficial cut. And this is a close-up of the scars. One interesting point is flap and graft necrosis that may happen actually, especially in inexpert periodontists, I can say. This is according to the fact that I do tutoring at universities, so I see inexpert periodontists performing surgeries. And basically, the survival of a flap of a graft, it depends on vascularization. So we have to create an adequate recipient bed. adequate recipient bed in terms of dimension, of course. We have to create a flap adequate in terms of dimension. So the coronal dimension should be equal or a little bit smaller than the pedicle area. And also the thickness, so an adequate thickness and not too thin, because otherwise it may encounter some necrosis. And as you can see, in this case, we have several mistakes, because we have a recipient bed not adequate in terms of dimension, bad dissipatization of this papilla, and these papilla are very small to receive both graft suture and flap suture. In fact, this area of the graft has been sutured too coronally, and the case ends up like this. This is 7 days after surgery. We do not know actually which tissue which tissue is involved by necrosis, graft, or flap, or both of them. But this is not the point, because the point is that at the end you end up with a little bit more thickness, but with a recession that are even deeper compared to the baseline. So this is very an issue for our patient that underwent surgeries and without any kind of improvement or benefit. So keep in mind flap and graft dimension to avoid necrosis, because you have always to think about vascularization of during the healing phase. Now we have reached the last part of our presentation, in which we have the external root resorption. Root resorption, you know, that is a normal a pattern of healing that may occur after the elevation of a mucoperiosteal flap and the repositioning of this flap above the nude surface. Fortunately, this is an infrequent event, thanks to the action of epithelial cells from the coronal aspect and the periodontal ligament cells from the most apical part and lateral part that works together, creating a barrier in order to prevent the early colonization of connective tissue, cells coming from connective tissue. Therefore, this is an infrequent event. However, we have some evidence regarding this occurrence after root coverage procedures, free gingival graft or connective subepithelial connective tissue graft. And the case report present in the literature reported different ways to solve this kind of situation according to the extent. So from a surgical restorative approach up to the extraction of this tooth. Of course, the key point, the key factor is the early diagnosis, because the earlier is the diagnosis, the better is the prognosis. And regarding this point, I would like to draw your attention on the importance to put even mucogingival patient under strict maintenance program, because this occurrence might be diagnosed mainly only during our professional oral hygiene, and we can detect them in very early. External root resorption, we have faced this kind of occurrence in our department in the last 10 years, let's say 7-8 cases that we have treated very successfully in the way that I'm going to show you. This is a case in which a connective tissue graft plus coronal advance flap was used after several years. So here is a control follow-up after 3-4 years, I don't remember. We see this kind of occurrence that is basically like an abrasion at the level of the cervical area. that we have immediately investigated using an X-ray in order to detect the extent, the shape, and we check also the vitality of the tooth. The tooth was vital. So we decide to go for this kind of approach that is called surgical restorative approach, in which a mucoperiosteal flap is elevated. The lesion is completely isolated using a rubber dam and recontoured using bars. The depth of the lesion was isolated using a liner because we were very, very close to the pulp, and we decided to use composite filling because we have several materials in the literature, but no evidence regarding which is the better. So we decided to use a composite, flowable composite, and the key point is to reach a very smooth surface in order to allow the reattachment of the connective tissue above the root after the healing. So the flap is repositioned in the initial position. And the treatment, as you can see here, was successful at a short follow-up, and also at 1 year and even longer period, as you can see here, with the stability in terms of vitality, stability of the treatment, stability of the gingival tissue. So I strongly suggest this kind of approach in case of this kind of occurrence, because the alternative is our first goal is to keep in the oral cavity the tooth affected by external root resorption, and we are able to perform an early diagnosis. We can save this tooth, especially because these patients are often very young patients treated for gingival sessions. A rare manifestation that may appear after the use of free gingival graft is the bone exostosis. And this is something that I've never experienced. In fact, I'm reporting some pictures taken from the articles that I found in the literature. And this is a manifestation that usually do not create so many concern unless it grows a lot, becoming very, creating discomfort for our patient. In case of very big exostosis, we need also to perform some differential diagnosis with other similar aspect that might be malignant tumor. So we have to perform a biopsy, elevating the flap, removing this area, and sent to for histological evaluation. And to conclude this series of post-surgical issue, we can have also manifestation of cyst-like area after subepithelial connective tissue that may appear as a cyst or just as a small fistula, from which we can see, after pushing, we can see the emergence of a very thick and white material that is completely different from past. This is very white and dense. And we have two explanations in the literature for this occurrence. Firstly, the presence of remnant island cells, epithelial island cells, or the fact that some type of connective tissue have very deep epithelial projection that can be included in the graft. So it can be considered complication, but also an error from our point of view in terms of dissipitalization. And just to give you an idea regarding how should we should be careful during dissipitalization. This is a very recent study published in 2019, but there's also a study published by Harris 2003 in which he showed similar findings, meaning that even in the presence of the best optimal optical visual, we can have, I mean, a microscope, we can have some epithelial left. All those samples have a small amount of epithelial cells present. So be very careful during the dissipitalization. And I would like to share with you this brief video regarding the dissipitalization of the graft, starting from the inner aspect, removing in case of presence of fatty and glandular tissue, and then use turn the graft, and we can remove completely the epithelium at the level of the external aspect. Of course, this is done under magnification, using a new blade, and using a very strong light, because with light we can appreciate the difference between the area that has already been dissipitalized and the area with the connective with the epithelium, and the importance of the dissipitalization of the vertical aspect of the graft. So let me conclude, remind you that the theoretical knowledge and accurate evaluation of patients together with practical skills may determine a successful result even in presence with complications. The most important aspect is to the communication, information to patient in order to create a great patient and doctor relationship. And I would like to thank you for your kind attention. This is my group in Bologna. Thank you.
Wow, thank you so much, Dr. Mounssif. My name is Alexandra. I'm one of the third-year residents at U of T, and we really appreciated this discussion this evening, and we'll probably all be watching it again once it's online, just so we can fully appreciate all the information that you've provided us with this evening. So really, thank you so much. So myself and my co-residents, Holly and Quang, will be asking you the questions that we've received from the audience this evening. And so we'll be rotating through the questions as they've come in, okay? So the first question is about the restorations. So the audience member wanted to know whether to perform the restorations before or after soft tissue grafting. In your case, you recommend doing it before soft tissue grafting, but the literature has been published on both sides. So why specifically do you recommend restoring the tooth before soft tissue procedure?
Yeah, we have always restored the cervical area before the performance of surgical procedure, because in that way you can appreciate the maximum root cover that you would like to achieve. Also, modifying the length of the tooth, especially in the aesthetic area, in which you can create the optimal length of your tooth. For instance, canine longer than the lateral and longer than the central incisor. Anyway, the reconstruction of the cervical area before it is easier, of course, without gingival tissues. And also, this is now mandatory after the World Workshop of Perio, thanks to the article published by Cortellini Bisada, in which we have to consider this as first step of our surgical restorative approach.
Great, Thank you so much. We love this article by Cordolini, and we've been trying to implement this in our clinic. Thank you.
You're welcome.
All right, thank you so much. That was a very interesting presentation. We learned a lot. My name is Holly Javinia, and I'm also a third-year resident at U of T. The next question we have for you here is, what are the disadvantages, if any, of the CTG tissue quality harvested with the de-epithelialized technique versus conventional techniques that yield more submucosal and glandular tissues? And they're referring more to long-term disadvantages.
Well, disadvantages, I think that well, first of all, the epithelialized gingival grafts may represent these disadvantages in terms of postoperative morbidity, but we have shown that this is not so true because we compare the epithelialized versus trapdoor, and we have shown that the postoperative is very, very similar. I think that sometimes for the epithelialized gingival graft, since the quality is excellent and is very stable, it might tend to grow a lot, creating sometimes an excessive thickness of the treated area. This is something that we have experienced. But in terms of disadvantages, I think that for instance, graft exposure, we have the same chance to have graft exposure independently from the harvesting technique.
Okay, thank you.
Thank you for a great lecture, Dr. Munseef. So the next question is, do you treat the root surfaces with any chemical agent? And is there any chemical agent that you would absolutely avoid?
Well, usually I use the EDTA, 24%. We have some evidence, but limited, regarding this material in root coverage, because a recent systematic review reported better outcome, but better outcome in terms of root coverage if you use it. However, the studies reported in the systematic review are not so robust in terms of evidence. So it is just for us a way to remove the smear layer from the surface, from the dentinal tubuli, in order to promote the interaction between the collagen fiber and of the tubuli and the collagen fiber of the connective tissue graft, the blood clot, let's say. So this is, let's say, an empirical use, not so evidence.
Perfect. Thank you very much.
Okay, so the next question is going back to composite, and if there is an older composite restoration on the root surface, the tooth in question to be treated, do you always remove it? And when you remove it, what filling material do you use to restore the tooth? And do all filling materials help reduce?
Well, if the previous restoration is already good at the level of in terms of length, in terms of color, you can use it. Just you have to polish it. Otherwise, I remove it because I need to create my new clinical CJ. And we use composite resins, basically not resin ionomer, because the color is not so aesthetic. Even we have several articles published by Santa Maria Group in which they use this kind of material. However, in our department, in my group, we use composite resin to restore as best as we can the cervical area in order to create a pleasant appearance similar to the adjacent teeth. And it's important to, especially to recreate the kind of convexity of this area over which we can suture the flap, the coronal advanced flap.
Great, thank you.
Okay, so our next question is kind of a two-part question. Could you please elaborate on the size of the sutures that you use, for example, 5/0 versus 6/0, why you'd use one over the other? And the second part is basically the type of suture, like the material choice, resorbable versus non-resorbable, etc.
Okay, yes, I use 6.0 PGA. This is a polyglottic acid. It is a resorbable material. The needle is 10 or 11 to suture, to perform the sling suture and the most apical suture at the level of the vertical releasing incision. For the graft, I fix the graft using 7.0, always PGA. Is a resorbable material always, and for the graft I recommend the small needle, 8 millimeter, because with 8 millimeter you are able to penetrate the graft and go immediately out there, and you are able to fix the graft in that exact position without moving it coronally. 5/0, I use it just for the palatal site after harvesting procedure, especially if the palate, I noticed an excessive bleeding in the palate, just there, or other type of periodontal surgery, but not in the buccal aspect, let's say.
Great, thank you.
The next question is a restorative question. For the class 5 restoration, what kind of profile do you prefer the restorative dentist perform? Is it more tooth contoured or more flat contoured in the restoration, the root surface restoration?
Is more, sorry?
Do you like the restoration to be more tooth contoured, like a natural crown, or a little more flat to get optimal root coverage?
No, I prefer very natural tooth, so a little bit convex. This area should be a little bit convex, but of course with an emergency profile similar to the adjacent teeth, not wide, not flat contour.
Perfect, thank you.
Okay, hi again. So the next question is about the suture sequence. So what sequence do you suture the flap for coronary advancement?
Yeah, so for single gingival recession, I think, right?
Yes, that's correct. Single gingival recession.
Okay, so in the coronal advanced flap for single gingival recession, we have 2 vertical releasing incision. So first of all, we start with the most apical suture that are located at the level of the end of the vertical releasing incision. So we start from one side and the other side, and then we can go coronally, knot by knot, from one side to the other side. Then at the end of the vertical releasing incision, in this way, if you have performed adequately the flap, the split thickness, so the flap releasing, you should be able to have the final position even without the sling suture. Then we can perform the sling sutures that are performed as I showed you the video. So penetrate papilla, anatomical papilla, a surgical papilla, go around the palatal or lingual cingulum, then we can penetrate the other surgical papilla, anatomical papilla, and close the knot in the first papilla. Usually one sling suture is enough. However, if you have that so-called oozing from the sulcus, or the marginal flap is not tight enough, you have to do one more, moving the knot on the other side, so on the other papilla.
Beautiful, thank you.
Do you have a preference for a surgical blade?
Yes, 15C. I use always 15C. It's my favorite one.
Okay, thank you.
Do you prescribe antibiotics for most of your CTG surgeries?
Actually, I do not prescribe, because first of all, we do not have evidence regarding mucogingival surgery and prescription of antibiotics. But in general, if patient is a healthy patient without any kind of needs in terms of pre-medication, I do not prescribe antibiotics after pedodontoplastic surgery.
So how about a resident performing the surgery and it's taking a lot longer than normal, and you know the tissue is a little more traumatized? Would you consider antibiotics at that point?
What does it mean, longer than normal?
So twice what you would.
5 hours, or I maybe considered corticosteroid instead of antibiotics, because it limits the swelling with the longer surgeries.
Perfect, thank you.
And the next question is about, you showed a case where you used a collagen membrane and then it was exposed. So how do you recommend managing the collagen membrane exposure?
But as you have seen in this case, no management you should do in the first healing. So we waited 1 month. Okay, so you can remove the suture, keep going with mouth rinse with chlorhexidine in order to keep everything very clean, but you do not have to do anything in that case, because it tends to resorb, not to create infection, the matrix. Therefore, we need to wait and let the biology do its course, and then reevaluate the situation, exactly as in the connective tissue graft exposure. Just one case in which you can consider to do something is when patient presents with flap or graft necrosis, and maybe it is associated with fever, lymphadenopathy. So you can or a sedation or pus, you can prescribe, for instance, antibiotics in this case. But the management should be waiting, at least in the first part.
Okay, and the question you just wanted to clarify, he was referring, or he or she was referring to sulcular exposure. Is there any difference in managing a sulcular exposure?
In the sulcular exposure, the difference is in the outcome, because the case I've shown regards the vertical erasing incision, so no impact on the final outcome in terms of root coverage. While if you have the sulcular exposure, you may the matrix tend to resorb, but that means that you have also flap shrinkage. Okay, so in that case you have a partial coverage or maybe even failure. So in that case, after 3 months at least, because you have to wait for the soft tissue healing, so then you have to reconsider your final situation or your new situation, and to evaluate this together with patient. Because if patient is not satisfied at all, you have to do a new surgery. And maybe in this case, you can't use a matrix. Maybe you have to use a graft.
Great, thank you.
Okay, and does de-epithelialization help with keloid management to blend the tissue?
How? Sorry, how? Maybe I didn't get the question.
So they're saying, does de-epithelialization help with the keloid management to blend the tissue?
The dissipitalization is fundamental because otherwise you can put the graft under the flap. So it basically is a technique, and this is not due because you have to blend the keloid-like appearance. The point is that the graft should be completely submerged. You have to cover completely the graft with the flap in order to avoid this kind of keloid-like appearance that is usually due to the exposure and not of the graft itself, let's say. Okay.
Thank you.
The next question is regarding that case with the external root resorption, where you place the composite restoration on it. Does connective tissue adhere to composite restoration? And are you concerned about getting deep pocketing after doing a connective tissue surgery over restoration like that?
Well, we should have an histology to answer this question, but I think that the new interface between the reposition flap and the composite should be or would be the long junction epithelium that we know that is a very strong kind of attachment that we have around teeth, and so far we didn't experience any kind of periodontal pocket in the fascial aspect in which we add the composite fillings. As I said before, we need to smooth as much as possible the composite restoration. So we should create a very smooth surface in order to promote this kind of reattachment. This is the point. So in our clinical experience, and also because we know that when there are also some studies in the literature that the reattachment of tissue at the level of the composite restoration or resin ionomer is possible and healthy without any kind of inflammation or probing.
Thank you so much.
Okay, so I think we're getting to the last questions from the audience, and then I know there's a couple questions from the panel. So I'll ask the last audience question, which is about frenal attachments when doing a CIF and CTG. So can you hear me?
Yeah.
Sorry. Okay, so in the case where there's a high frenum or frenal attachment, how do you manage the frenum when you're doing a coronally advanced flap and CTG in the maxilla or mandible?
Well, in the maxillary area, I'm not afraid about the frenulum because we can manage it using the split thickness, the deep and the superficial. The point is different for the mandibular area, the anterior mandibular area, in which it might be a very an obstacle. So it depends on how is strong this insertion and how is the height of the insertion. Sometimes I consider the idea to perform a frenulectomy before the surgery, before the coronal advanced flap plus connective tissue graft. But if the frenulum is small and so strong, I usually remove it during the performance of surgery from the inner aspect of the flap.
Great, thank you so much.
Welcome.
I think that this might be the last question, Dr. Munseef.
Okay.
So do you do tunneling for your CTG sometimes, or do you always do flap? That's part one, there's part two.
I tried sometimes tunnel, but my preference is for coronary advanced flap. So let's say that I'm very skilled with coronary advanced flap and less with tunnel technique.
Okay, because I was discussing this with my instructor today because we were doing it. It's like, when do we decide to tunnel and when to do a coronary advanced flap? So,
well, I think that this is a very interesting question, but you know that in the literature we do not have this answer, and I think that this is because most of the time the choice of technique, it's up to us and up to our preferences and up to our skills. So of course we have some clinical situation which we can perform both technique, but if we ask me or ask a tunnel fan, we of course we can answer with two different techniques. So I don't know what is your idea, but this is mine.
perfect, thank you.
You're welcome.
Well, Ilham, I mean, hi, hello again. I have no words. I mean, this is a fantastic, outstanding presentation. I think it was a treat for everybody who attended, and I know that
you know, a lot of stuff. So I think.
No, I think as Alex said, this is going to be one that we watch a couple of times over again, because every single time there'll be another pearl or two that we pick up. I know it's getting late where you are, so I don't want to keep you for too long. But I have a comment and a question. Sure. My comment is I really appreciated that you showed the intraoperative complications, because a lot of times we're so focused on the after, the post-operative complications and the bleeding and infections. But what you showed with the perforations and how to deal with them, I mean, this is something that no matter how good you are or how careful you are, this sometimes can be unavoidable. And sometimes I'm stuck there. Do I treat this? Do I not treat this? So I really appreciate the clarity that you provided with your presentation. The question I have is regards to that case you showed with regards to the keloid formation. I've had this happen to me a number of times, and when it happens to the posterior, no one really cares because the root coverage aesthetic score isn't affected and you get 100% root coverage, so you've achieved a major goal. What do you think the mechanism of that is? I mean, you talked about one where you get dehiscence and exposure of the graft, but do you think it could also be because maybe the de-epithelialization wasn't sufficient, and so the healing is almost like a free gingival graft after the dehiscence of the flap itself, creating this sort of two-step in tissues? Yeah,
it might be. But usually when we face this kind of occurrence, in my experience, of course, I see it because the flap tends to shrink. So I had a kind of flap dehiscence, even very small, but you need just 1-2 millimeters of flap dehiscence, flap shrinkage, and then immediately you have the exposure of the graft. And as I said before, since the graft that we use is a very stable graft, and it tends also to increase, because this is something that we have shown in our randomized clinical trials. The graft that we harvest immediately under the epithelium is very stable, and it does not resorb so much, and it tends to grow over the time. And sometimes this growth over the time may determine also the exposure. So maybe yours might be an explanation also.
Excellent. Do you ever use a surgical dressing on top of your palatal recipient site, or is a collagen sponge sufficient?
Well, the beginning, I used to use it very often. Nowadays, we have others, let's say, materials that we can use. Cyanoacrylate, for instance, have been shown to be effective to reducing the postoperative morbidity. And nowadays, I use sponge, cyanoacrylate. When I have a very scared patient, very anxious, that I'm sure that he or she is going to call me every day, I put sutures and also the periodontal dressing, just to be sure that patient is comfortable and not anxious regarding palatal bleeding. But most of the time, just the sponge and cyanoacrylate are more than enough, because the harvesting procedure that I apply is very, very superficial. So you do not experience so much bleeding.
Fantastic. And one last question is with regards to the volume stable collagen matrix. In your study, you guys halved the thickness of that matrix. Was that to counter, the thickness is normally 6 millimeters, which might be too thick for the buccal flap. And even halving it to 3 millimeters, even despite that, do you think that the necrosis of the vertical incisions was because the flap, the matrix still continues to expand during the healing after the patient goes home?
Yeah, it might be a point, this one, and especially because that case was in the mandibular area. The only case with exposure that kind of exposure was in the mandibular area, and I think that also the position, so the presence of muscles, excessive strong forces in this area might be the cause of this exposure, because in other zone of the mouth, so in the maxillary area, we didn't experience at all this kind of occurrence.
Yeah, anterior mandible and is anatomically a very harsh environment, right? So no surprises there. Well, Ilham, thank you so much. This was
you're welcome.
A wonderful, wonderful presentation. I think everybody was really just blown away by your thoroughness and your explanations and your clarity. And we had a lot of questions, and some of them we didn't ask because they weren't related directly to complications. So we're just going to have you back for some point to talk about the technical aspect of soft tissue grafting for root coverage. So maybe a part 2 in the future. We'd be delighted to have you.
I'm glad you enjoyed this presentation.
Thank you, and enjoy the rest of whatever's left of your evening, and we look forward to see you soon. But before everybody goes, I'm just going to share my screen one more time. I want you guys all to save the date for Monday, March 22nd. We're back to our regularly scheduled Monday evenings for the Oak seminars, where we'll have Dr. Charles, aka Chuck Schwimmer, speaking about the spot drilling protocol for partial extraction therapy. So we move from soft tissue now to hard tissue. So speaks to the diversity of topics we have for the Oak seminars. So everybody stay safe, and thank you again, Ilham. I really, really appreciate it. And we'll see you soon.
Thanks for the invitation. Thanks to all the scientific committee.
Thank you.
Bye.
Peace out, everybody. Bye-bye.
Bye.